Good evening, everyone. I am Dr. Fernandez Becker, and today my colleague, Dr. Chetan Khosla, and I are delighted to be here to talk to you about some celiac disease research updates. Okay, first let's start with an overview of our webinar. We will first do an introduction to celiac disease, then go over diagnosis, transition to the gluten-free diet, and lifelong management of celiac disease. After each section, we will discuss some leading questions and celiac research, and we encourage the audience to type in some questions that they have for us to address as well. Let's start with an introduction to celiac disease. So why do people avoid gluten? When we talk about gluten-related disorder, there are three broad categories that we consider. Autoimmune, which is celiac disease, allergic or wheat allergy, and then there's not autoimmune and not allergic, which is non-celiac gluten sensitivity, which is very poorly understood. Today, our focus is going to be celiac disease. So let's start with what is gluten. Gluten encompasses the storage protein in wheat, rye, and barley. It is proline and glutamine rich, and it's a proline and glutamine rich protein that activates immune response in celiac disease. And it has a high proline content that makes it resistant to the brush border enzymes in the intestine. So it gets broken down so far, but there are chunks of it that remain, and those small segments of the protein are able to activate the immune response. So let's look at the big picture. So what we have here is a dietary protein that's represented by donuts, is ingested, and this results in intestinal damage. In the small intestine, the lining is organized in small finger-like projections that are called villi, and these get destroyed in celiac disease. And we'll talk a little bit more about how this happens. Before we get into the details about how the injury occurs in celiac disease, I'd like to go over just some basic small intestinal anatomy and physiology. So the small intestine is a vital organ, and really it is the only part of our luminal GI tract or gastrointestinal tract that is critical. You could live without an esophagus, a stomach, or even a colon, but you cannot live without a small intestine because that is where most nutrients are absorbed. And also it is a vital immune organ, our biggest immune organ for that matter. The small intestine is approximately 20 to 22 feet long. And it is lined, the lining is organized in villi, these folds or little finger-like projections that are called villi that increase the surface area. And what you see here is a magnification of a villus. And there, what you have is that the lining of the villus are a single cell layer of cells that are called enterocytes that line the intestine. And in the core is where you have the blood vessels and the immune cells. And this is what it looks like under a microscope. So you have a single epithelial cell layer. And in the core, or what we call the lamina propria, is where our immune cells reside and where a lot of the action in celiac disease occurs. Now, let's give an overview of how celiac disease occurs. So what you have is that ingestion of a dietary protein in a genetically predisposed individual, and we'll talk a little bit more about that in the course of the webinar, causes an inappropriate immune response. And that leads to inflammation. And so in a sense, the body is recognizing gluten as something harmful, and it's trying to protect you. And it's this friendly fire or activation of the immune response that results in damage or injury to the lining of the small intestine. And this is an overview about what is happening at the molecular level. In the top panel, what you have is a cartoon of the villi. So the villi are the little peaks or the mountains, and the crypts would be the valley. So the crypt is where the cells that will grow up to line the villus are. And what you have in the bottom panel is a magnification of the tip of a villus. Again, there is this single epithelial cell layer that lines the villi. And what you have here is that gluten somehow gets past those epithelial cells into that lamina propria compartment where the immune cells are. There's also a protein that is found that is called tissue transglutaminase, which is critical for the pathophysiology of celiac disease that modifies gluten. And it's that modified form of gluten that is then picked up by the immune cells and leads to activation of the immune response. And what do I mean by that? Well, there are chemicals or cytokines that are made that affect the lining and increase permeability. And there's also activation of other immune cells that will then cause injury to the enterocytes. And there's also activation of special cells that are called B cells, which make antibodies, and antibodies against tissue transglutaminase or TTG, which is that protein I told you modifies gluten, and antibodies to gluten are made. Now, this shouldn't happen. The body shouldn't make antibodies against its own protein. So this is what we call autoimmunity. This is an example of autoimmunity. And it's also not understood why the body makes antibodies to gluten. And what happens over time is that repetitive exposure to gluten increases the permeability, so the lining becomes a little bit more leaky and more gluten gets in there and revs up this whole process. And over time, the villi get shorter and shorter and shorter as the injury ensues, and the crypts get deeper. And what does that look like? Well, grossly, if on the left panel here you have a normal small intestine, and the folds are very delicate, and it almost looks like a sea anemone. However, over time, those villi are lost, and the lining of the small intestine becomes smoother and almost like snakeskin-like, and it loses its ability to absorb nutrients. Now, celiac disease is not it's not exclusively in the intestine. It can also affect many organs in the body. And this is a very busy slide, but the point of it is to show you that so many aspects of our body are affected by celiac disease. So that wraps up our introduction, and now we wanted to discuss some leading questions in celiac disease pathophysiology, and that Dr. Kosla will address. The first is, how does a genetically predisposed individual develop celiac disease?
So thank you, Nielsen. This is a question both Dr. Fernandez-Becker and I get frequently from many people in our even scientific researchers, but certainly also lay people. We know that there is a strong genetic component to celiac disease. And I'm guessing everybody in this audience has heard of genes like HLA-DQ2 and perhaps even HLA-DQ8. Those HLA genes have a disproportionate share of responsibility when it comes to inheritability of celiac disease. One can explain about half of the inheritability of celiac disease based solely on those genes. However, they're not the only part to the genetics of the disease. It's known that there are other genes also involved. There's two other things beyond HLA that we know for sure you need to get celiac disease. The first one, of course, is gluten. If there's no gluten in the diet, there's no celiac disease. And the second one is a certain type of a T cell that is looking at gluten in the context of HLA-DQ2 and then initiating an inflammatory cascade. So we know for a fact that in addition to HLA-DQ2, a celiac patient will need gluten exposure and these T cells to get celiac disease. Beyond that, everything else is up for grabs and up for debate in the field. Different people have different theories, and I'm happy to address any of your pet theories, but this is about where the frontier is in terms of research today. Does that give us what we need to move to the next question? There's a question that came up from one of the audience. If you have tested positive for the gene, how often should you get blood work to check levels? Nielsen, what would you say in response to that question?
So the interesting thing about the genes is that they're necessary for you to have celiac disease, but the vast majority of people who carry the genes do not have celiac disease. About 30 to 40% of our population carry the genetic susceptibility, but it's only about 3 to 5% of those individuals that develop celiac disease. So just having the genes doesn't mean that you have the disease, and there is no recommendation for you to routinely have celiac serologic testing done. But if there's symptoms and there is a clinical suspicion, and we'll talk about what those are, then testing for celiac disease is warranted.
There's another question that TTG can be elevated from cow's milk also. Are there different TTG tests for different autoimmune conditions, or is TTG highly specific to celiac? Nielsen, would you like to take that?
Sure. And I might want you to.
I
Yes,
can
I
get
as well.
started while you formulate a more coherent
Yeah.
answer. This is an
Well,
excellent question.
that is a
Yeah,
great question.
thank you very much.
So
There is no scientific theoretical basis to explain that TTG. First of all, let's be clear. When we use the word TTG in celiac, we're not talking about TTG itself. We're talking about autoantibodies that our body makes to TTG. All of us have this protein called TTG, and it's doing a good thing for us for the most part. So there's nothing wrong with your TTG. The thing that's anomalous in a celiac patient is that your immune system makes autoantibodies that react against TTG when it shouldn't be doing that. So I presume you know that, and I'm going to assume that that's the case. But if I can rephrase your question, can TTG autoantibodies be elevated from cow's milk? There's no theoretical foundation for that. However, I'm not aware of a good study that has one way or the other established whether cow's milk in a celiac patient can elicit gluten autoantibodies against TTG. Are you, Nielsen?
I'm not. No, I'm not
It's a
aware.
good question, and I'll make a note of that
May
to look it
may
up.
I jump in? I
Of
don't
course.
want to
Yes, please.
interfere,
Thank you,
but this
Neil.
is
Thank you, Hillary. Please do so.
yeah, this is actually something that has been of interest to me that I have done some literature, but there's not a lot on it, so I wouldn't expect most people to be familiar with it. But this is a great question, and there is a subset of patients that we have published when I was at the University of Chicago of kids who were thought to have refractory celiac, ultimately were found to have what appeared to be a cow's milk protein intolerance. And if you go back in the literature, what is thought the base structure of casein has a lot of similarities to the base structure of gluten. And it's thought that the process that can cause these elevated TTG levels in response to milk is what we call antigenic mimicry. And the patients that we've found this happen in the most are those who, at the time of developing celiac disease, have large consumptions of dairy too. That's the patients we've seen in the most. And it's thought that when, as they've talked about a little bit, the gut kind of gets this leakiness to it and things are getting across inappropriately, that in addition to the gluten getting across the wrong way and causing this inflammatory reaction, the casein is able to get across the lining as well. And because of those kind of similarities in the two structures between the gluten and the casein, the body starts to inappropriately react to the casein in cow's milk. And the very interesting thing in the subset of patients I've seen and treated like this is that they have some mild persistent symptoms, mild persistent elevation of TTG. You take the dairy away, everything normalizes, but it's not a lifelong condition like celiac. And interestingly enough, if you give these individuals a period of time off dairy, it can be reintroduced, and those individuals develop what we call a tolerance to it. So it doesn't cause a return of inflammation the way that celiac does, because celiac is this autoimmune-like condition. It's thought that, again, it's this misinterpretation of the casein, that base structure that looks like gluten, that the body is inappropriately reacting to it, almost mistaking it for gluten. But you can break the cycle, which is interesting, which you can't do with celiac, if that makes sense.
Very interesting.
Yeah, it is a very, very interesting process. It's I didn't want to interfere, but it's something that I've been very interested in over the years, and so I've looked into it a lot.
Mhm.
Well, there you have it from the expert.
Mhm.
So let's quickly just address the second question on the slide before Dr. Fernandez-Becker moves on to the next section, because I'm sure there's questions in that section too. To the extent you are interested in knowing how researchers study celiac disease, I think the simplest way I can describe it is in a historical context. Celiac disease was characterized as a gluten-sensitive disease in the late 1940s, early 1950s. For the first 40 years of the disease, the only way for a researcher to study the disease was in celiac patients themselves. So most of what we learned in the first 40 years came by studying patients directly. By the late 1990s, and certainly by the turn of the century, approaches started to become possible where you could study some critical aspects of celiac disease in test tubes. And that opened up a whole new understanding of what that has led to much of what we know today about celiac disease, because in these test tubes you could put molecules and you could put cells, and you could see how the molecules interact with other molecules and how the cells interact with the molecules and with each other, and a lot was learned from there. Fast forward another 20 years, by the late 2010s, a third approach started to become possible in the field, where researchers were able to take what they learned about celiac disease by studying patients and in the test tube, and reverse engineer what they learned into animals that could be manipulated in the laboratory. And from that came animal models of celiac disease, and those are starting to teach us a lot about the disease too. So in a nutshell, it's the patients who teach us and have historically taught us the most important things about the disease. Test tubes have taught us something, and most recently, animal models are also teaching us something. Nielsen, you want to move to the next section?
Absolutely. Whoops. Okay, so now we're going to talk about diagnosis. So in order to make a diagnosis, there has to be clinical suspicion. And so somebody has to think about could this be celiac disease in test? And one of the questions that comes up is, how do patients with celiac disease present to the clinic? And this pie chart gives us an idea of what that looks like. And what you can see is that the majority of patients do have intestinal symptoms. Many patients do experience diarrhea. However, many patients also come to the clinic because of other reasons, because they have unexplained weight loss, they have an anemia that's unexplained, or decrease in bone density. And interestingly, over the past couple of decades, most patients come to clinic not because of intestinal symptoms, but because something else is happening. And some of those patients we find incidentally, we're evaluating something different and we stumble upon signs and symptoms of celiac disease. And a huge chunk of the patients are also we pick up because we screen first-degree relatives of patients with celiac disease. And many of those patients do not have symptoms. So once we suspect celiac disease, the next step would be to look at the blood, looking for those antibodies against tissue transglutaminase, which is the preferred screening test. However, we also have the ability to test for anti-gluten antibodies, and the toxic component of gluten in a celiac patient is the part that is called gliadin. So what we look at is the anti-gliadin antibody. Now, each organ system has its own type of antibody, and for the GI tract, it's IgA. So the tests that we rely on are the IgA variety. And the good thing about these tests is that they are highly sensitive, and that means that they're very good at picking up the disease, and they can pick up the disease accurately 95 to 98% of the time. The other thing is that they're highly specific, meaning that when they're positive, we can trust that the patient does have celiac disease, and it's accurate about 98% of the time. There are a few caveats to this, however, that it's important to remember that the patient should not be avoiding gluten when we test these antibodies. So once a patient is on a gluten-free diet, those antibodies go away, which is why it's very important, if there is suspicion for celiac disease, to have an evaluation before starting a gluten-free diet. And we'll talk a little bit more about that as we go along. And also, I told you that the IgA variety of these antibodies are what we rely on. Well, about 2% of patients with celiac disease have IgA deficiency. So we check an IgA level, because if it's low, then we may have to rely on the IgG variety, because the conventional tests are not may not be accurate. Okay, so the next step in making the diagnosis is to confirm the diagnosis. Now, there's a little bit of a divergence here, because there are criteria to make the diagnosis in children that do not require an endoscopy. However, in adults, an endoscopy is considered a gold standard. And what we do is that we pass a fiber optic endoscope that has a camera, and we pass it through the mouth into the esophagus, past the stomach, into the small intestine. And it allows us to directly visualize the lining. This is the same picture I showed you before. So in a normal patient, what you have is a nice, delicate fold with fluffy villi. And under the microscope, so we take small pinch biopsies that then the pathologist can look at us. And what you see is that the villi, the little peaks, the villi, and the valleys are the crypts, and the villas should be at least 2.5 times taller than the depth of the crypt. So this is in a normal case, you have a very nice, thin, papery villi. However, in a patient with celiac disease, visually, what we see is that the villi are gone, and we see notching or scalloping. There's also nodularity, and there's a snakeskin appearance to the lining. And what we see under the microscope is that the villi are gone, and what we have is very deep crypts. Again, evaluation should be done on a gluten-containing diet, because once the patient is on a gluten-free diet, then these signs or the injury begins to heal. And sometimes this makes it difficult to make the diagnosis. Now, this is a busy slide, and I'm not going to go through everything, but the point here is that making the diagnosis could actually be quite difficult. And this is an algorithm from most recent guidelines. And on one hand, you have in a patient who's on a gluten-free diet, it might be hard to make the call because the antibodies may be falsely negative. The biopsies may not be conclusive. And there, sometimes we check for those genes that we talked about, because they have an excellent negative predictive value. In other words, if these genes are absent, then we essentially rule out the diagnosis of celiac disease. But in patients who do carry the genes and are on a gluten-free diet, the standard of care is to reintroduce gluten in the diet so that we can induce those changes and make the correct diagnosis. On the other hand, the antibodies are accurate, but no blood test that we have is completely perfect. So they could be falsely positive, they could be falsely negative, and we have to take into account the clinical situation. And to complicate matters, those signs that I showed you, those changes that happen inside the intestine of patients with celiac disease, well, it could be seen in other disorders as well. So taking a careful history and also looking at what the antibodies are very important. But there's other disease entities that can be celiac disease lookalikes that we consider, particularly when there's patients who are not getting better on a gluten-free diet. And that sums up that section. And here are the leading questions that we came up with to discuss. The first being how to diagnose a patient who is already on a gluten-free diet.
Right. So before we take these questions, Nielsen, there was a question about in the chat about neuropathy symptoms, neuropathic symptoms. Would you like to take that real quick?
Yes. So neuropathy can occur in celiac disease, and a lot of the time, this is because there may be malabsorption of micronutrients, and in the small intestines where you absorb most nutrients, so there could be deficiency in micronutrients that could then lead to neuropathy. But there is also situations when the celiac disease itself could affect the nervous system. And unfortunately, that is poorly understood. But patients can develop neurological symptoms related to the disease process itself that is not related to micronutrient deficiencies.
Thank you. So about the questions on this slide. So how to diagnose a patient who's already on a gluten-free diet. This is, of course, everybody understands a challenge, but an important challenge that science has to come up with an answer to sooner or later. As Dr. Fernandez-Becker mentioned in the slide right before this, there are emerging protocols for making definitive diagnoses in patients who have been on an extended gluten-free diet before they get a diagnosis, but by and large, they all involve some amount of gluten. And therein lies the rub for somebody who's doing just fine on gluten and who's doing just fine on a gluten-free diet and wasn't doing well on gluten. I think the best simple answer I can give you to question one is, I personally believe there will come a day when we can answer this question for the simple reason that those T cells that I talked about that are sine qua non of celiac disease, those inflammatory T cells that recognize gluten in the context of HLA-DQ2, those cells exist in a celiac patient's gut, whether or not they are seeing gluten. That patient is seeing gluten. And so when researchers come up with practical methods to be able to detect those T cells in a manner that does not involve giving a patient gluten as part of their diagnosis, I think this will become a solved problem. If you were to then push me and say, how long will that take? I don't think that's going to happen in the next couple of years, but it could happen in the next 5 to 10 years time scale. So I'll just leave it at that. And if either Nielsen or Hillary have a different perspective, feel free to chime in.
Absolutely the same perspective.
Good. What to do if a patient has a positive serologic test but a normal biopsy? So these are patients who the field calls potential celiac patients because they have something that is generally considered as Dr. Fernandez-Becker explained in that slide, the serological tests are quite sensitive and specific. And so if they're detecting some positivity, they're telling us something. But if the biopsy is normal, the doctor cannot say that this is a celiac patient, with the exception of young children where there is a very high serologic titer level that is now starting to be used in some parts of the world as a sufficient criterion for diagnosis. I think for the most part, Nielsen, if you want to chime in on this in terms of where you see the field going over the next few years, maybe it's better if you did that, because the science is definitely showing that a significant fraction of these people, if they stay on a gluten-containing diet, will ultimately show the signs and symptoms of regular celiac disease. It's just a question of how long.
Exactly. So the way I approach this is that it depends on context. And there are situations where there might be transiently positive antibodies. And if the patient is completely asymptomatic and doing well, then I think it's reasonable to monitor. But if a patient is having intestinal symptoms or symptoms that are suggestive of celiac disease, even if there's a report of a normal biopsy, I tend to recommend a gluten-free diet. And the other caveat that I think we have to discuss is that there is not a lot, unfortunately, there's not a lot of standardization and expertise in interpreting in small intestinal biopsies. So some biopsies that may be considered normal may not really be normal. And I see that also as my eyes are very attuned to celiac disease, so I might pick up some subtle changes that someone that doesn't see celiac disease often may not. So there's a lot of variability, but I think that there's a lot of research being done in this area, and we'll have more clarity.
Hillary, before we move to the next section, there's a question in the chat that perhaps you might want to address. We have 2 children diagnosed celiac. A third son had a negative blood test. Should he get retested, and how often?
Sure, absolutely. That's a great question, and something that comes up a lot. And kind of like Nielsen was saying about best practice protocols and standardization, if you ask probably 100 different GIs, you'll get 100 different answers as to how frequently someone should be tested. As a whole, from my experience over the last 15 years, most GIs on average recommend repeating screening once every 3 years, because celiac can occur at any time in someone's life, from the very first time they're exposed as an infant all the way up to, shortly before they pass away. I mean, it can happen at any time in someone's life. So, on average, most of us say that we recommend all first-degree relatives. So, that is either the parents, siblings, or children of the affected individual get screened roughly once every 3 years. But depending on who you talk to, some practitioners will do annually just because it's an easier thing to remember so it doesn't slip through the cracks. Some people are good with once every 5 years. There's no absolute right answer for that. If anybody had any symptoms sooner than that, anything from like Chaden and Nielsen was saying, the symptoms are all over the place. So persistent headaches to standard GI symptoms to slowing of height and weight growth to, a bone fracture for no good reason. Those would all be reasons you may want to check a little bit sooner. But again, on average, depending on the doctor you talk to, we recommend once every somewhere between 1 and 5 years indefinitely. And as Chaden and Nielsen brought up before, if you get the genes and you don't have the genes, the likelihood of you developing celiac is near zero. And so those individuals don't necessarily need to keep getting screened. But if you get the genes done and you have them, it means you have the possibility, not absolute, but those are the individuals that should continue to get screened going forward. I
Thank
hope
you.
that answered the question. Sure.
Yes, and thank you. And while you've been answering that question so well, another question has popped up that maybe you want to address, which is if a child who has been on a strict gluten-free diet has a dermatitis, skin rash, can that be celiac related?
So technically, if they're on a strict gluten-free diet and really eliminating all gluten, kids are incredibly resilient. And having refractory celiac or ongoing celiac-related symptoms when you are 100% gluten-free in children is not very common. In adults, we see that more. So if a rash came up and someone's already 100% gluten-free, I would suspect it's either not related to it or they're still getting exposed to gluten and it's just not being recognized. The one rash in particular we see, and I'm sure Nielsen could speak much more on this because we really don't see it a lot in kids, but it's called dermatitis herpetiformis. And that's really the main rash, and Nielsen can speak otherwise if I'm speaking incorrectly here, but really the main rash we think about with celiac, things like eczema and those types of rashes really haven't been shown to have like higher rates of presentation in celiac patients. And again, dermatitis herpetiformis, we really don't see very often. I've never, in the last 15 years, I've never seen a child who develops that, but I'll let Nielsen talk a little bit more from the adult perspective.
Yeah, yes, that's absolutely right. And I don't see it very often, but it is a very small vesicles that are intensely itchy. They tend to occur in the extensor surfaces of the arms, so the knees, the elbows, the back, the bottom of the scalp, and diagnosis would require having a biopsy. And a lot of so many patients with dermatitis herpetiformis do not have intestinal symptoms, but if you were to look and biopsy the small intestine, about 85 to 90% of them will have changes in the intestine. And it data shows that what's happening there is the same reaction that occurs in the intestine is occurring in the skin.
Maybe we should move to the next section just into the
Sure.
interest of time.
Okie dokie. So we're going to talk briefly on the transition to the gluten-free diet. So once the diagnosis is made, then, in order to break the vicious cycle that we talked about, you have to take gluten out of the equation. And the gluten-free diet is basically avoidance of all grains that contain wheat, barley, and rye. And part of this is really, there's a very big learning curve because you have to understand what foods contain gluten. And sometimes the name may be a little deceptive. And it is not only learning about the gluten-free diet, but it's also implementing it and then maintaining it. So this is a very, very big lifestyle change. There's also, one would have to consider hidden sources of gluten, which can be found in a lot of different places that you wouldn't think. Like soy sauce is supposed to be gluten-free, so it doesn't have gluten, but soy sauce does. And in some of foods, the problem is cross-contamination. So these are all things that the patient has to learn. And I will say one other thing about hidden sources of gluten that sometimes it's not very noticeable is that sometimes medication fillers or supplement fillers have gluten. And sometimes I've had situations where a patient is okay and no medication changes, but all of a sudden showing signs of active celiac, and it turns out that a medication that they've been on for a long time, blood pressure medication or something like that, the manufacturer has changed the filler, and all of a sudden the patient is now being exposed to gluten via that way. And that could be very challenging because there's not a lot of experience here. The pharmacist may not be knowledgeable on it, and sometimes we have to call the manufacturer to figure things out. So it could be very tricky. And these are the questions. The first one will be how to tell if a particular food product is gluten-free. Dr. Kosla, can you address that?
Yeah, in fact, these two questions are almost the interest level in these questions is clearly going through the roof these days in the celiac community, as is illustrated by the questions that are coming up in the chat as well. By now, all of you know that by now that there are a number of products that you can buy that will that are designed to help a celiac patient tell if something they're putting into their mouth has gluten in it or not. And there are also emerging products that are designed to tell whether a patient has been exposed to gluten or not in the recent past being typically within the past 24 to 48 hours. All of these tests are essentially based on the same technology, which is that there are some commercial antibodies that recognize pieces of gluten quite well, with sensitivity and specificity that makes them interesting tools. And so these antibody tools have been deployed in everything ranging from devices that you can connect to your iPhones to dipsticks that you can you can stir in your milkshake or yogurt, to things that you can do sort of like your COVID type tests, but done with stool or urine instead of nasal swabs. There's a whole battery of tests available. We're deliberately not taking a position in this webinar one way or the other about to promote one type of test versus another. They're all interesting new developments in the field. And it's really the experiences of patients like yourselves that will tell the manufacturers and developers and the broader community of researchers, including ourselves, whether these products are effective or not. So I would just say they are encouraging developments in the field. They are starting to be more and more widely used and the jury's out on what their ultimate impact will be in terms of the health and quality of life of a celiac patient. I will, however, say none of them are FDA validated, because that's a whole different kettle of fish in terms of validating those tools. So if you're looking for an FDA seal of approval on those tools, you're not going to find them on any of them. So we are in, as a celiac community, we are in this world where we get to do our own experiments and figure out what works and not, and what doesn't. So that's probably the best answer I can give you on these tools. But I generally think that they are a good development for the field, and hopefully there will be some really promising tools that come up to the top. In terms of how to tell if a patient has adequately healed, the current gold standard, as Dr. Jericho and Fernandez-Becker will tell you, is to do a repeat endoscopy on a patient a few years into their disease and see if they have healed adequately in the small bowel. Now, while that's a valid way to confirm healing, it is a fairly invasive way, it's an expensive way, and it's hard to be able to navigate all the processes for all the patients over there. So this is an area of intense research in the coming years. The next slide actually shows an example of a tool that Dr. Fernandez-Becker and a postdoctoral fellow in my lab have been piloting. What you're seeing over here is a red-colored tool that was mixed with a freshly isolated biopsy from Dr. Fernandez-Becker's endoscopy suite, from a patient who had active celiac disease, a patient whose celiac disease had mostly recovered, and a patient who underwent a biopsy but turned out not to have celiac disease. And I think you can just look at these pictures and tell that there's something interesting going on over here. So now this tool was built based on animal studies and test tube studies, and it's going to take a long time to tell if it's going to be useful or not. But this is effectively where the research is going, to be able to develop minimally invasive methods to be able to monitor intestinal healing in a lifelong condition. Do you want to move to the last section for a few minutes?
Alrighty, so the next section is lifelong management of celiac disease. Okay, so this again is an algorithm, and it's a very busy slide, but it's basically a summary of the guidelines of, once the patient has the diagnosis, how do you follow this person? And generally in the first year, we follow relatively closely, and at least in the adult population, we check the serologic test, the antibodies every 4 months or so until they disappear, which happens usually at about a year. However, there are slow responders, and there are people where it may take longer than that. And then at every juncture, we basically assess the symptoms. Are things getting better or not? We tend to check micronutrient deficiencies very early in the course so that we can replete them, and we follow those over time. And if there are inappropriate, if patients are having symptoms or the response is inappropriate, that will trigger an evaluation. Part of it is referral to a dietitian that has expertise in the gluten-free diet, and go over the diet with a fine-tooth comb, trying to figure out, is there gluten in is the patient getting exposed to gluten? And in the absence of that, then we look for other explanations for symptoms, and that might require some tests that may require repeat endoscopy. If all goes well, we also monitor we we have what we call health maintenance. So we keep track of bone density, nutrition. We recommend certain vaccinations in adults, like the pneumonia vaccine, because a small subset of patients, the spleen may not work as well. So you may not be protected as well against encapsulated organisms. That's a common cause of community-acquired pneumonia. We recommend a yearly flu. We recommend shingles vaccine. Now, all of this, like everything in medicine, is a risk-benefit evaluation. Like Dr. Kozla said, we consider doing intestinal biopsies 2 to 3 years after the diagnosis and the implementation of the gluten-free diet. And this, again, is a shared decision-making. There's pros and cons to every decision we make. And some patients prefer not to have a biopsy, and they're doing great, and we just follow. Now, what can go wrong? This is an important section to go over, because unfortunately, many patients who have celiac disease and go on a gluten-free diet continue to have symptoms. And the big question is always whether celiac disease is the cause of the symptoms or there's something else going on. And 4 broad categories that we consider are: first, celiac disease is not the diagnosis. I told you that they were look-alike. So if the gluten-free diet is not working, then could there be something else? The other possibility, the most common reason, is that they're getting gluten somehow, and there's difficulty in adhering to the gluten-free diet. However, there's also conditions that tend to occur a little bit more in patients with celiac disease. And then there's the dreaded complication of something called refractory sprue, where the inflammation is no longer under the control of gluten. And refractory celiac disease type 2, it's a very rare but a very serious condition, very aggressive, and it is called, in Europe, it's called pre-lymphoma, because about 50% of patients who develop this go on to develop a very special type of lymphoma that's called enteropathy-associated T-cell lymphoma. Exceedingly rare, and in my 15 years at Stanford, I've seen it once. This is what we think about in patients who continue to have symptoms despite being on a gluten-free diet. You will see that the majority of patients, gluten exposure is the #1 reason. But many patients will have overlap with other diseases like irritable bowel syndrome. And the symptoms with irritable bowel can be very similar to that of celiac disease. And these are 2 very common diseases, so it's not surprising that they could occur in the same patient. But we also look at small intestinal bacterial overgrowth. Some people are lacking enzymes in the brush border that break down carbohydrates, the most common being lactose. But we also have a lot of patients who have microscopic colitis. And we see refractory celiac disease, even though it's rare, is always in the back of our heads, because it's the one condition that we wouldn't want to miss. So that wraps up that section. And here are the questions that the leading questions here. The first being, what causes variability in the symptoms?
Yeah, this is a question that I would say, regrettably, the field of celiac disease researchers like myself have not put enough work into, but hopefully it's changing. Most of celiac disease research thus far has focused on trying to understand the biology and chemistry that causes the actual disease, the root causes of the disease. That said, everybody knows, certainly the patients have known this always, and the doctors have too, and the researchers have too, that pathogenesis can give rise to very different symptoms in different patients. And we don't quite understand that. So I think the best way I can answer this first question is it is an important question. The good news is researchers are starting to recognize it's an important question that can teach us some very important things about the disease, but we still are a ways away from satisfactory answers to this question. There were a few questions about medicines, and there was one in particular, will there be a cure? I'm going to sound like a broken record in my answer to this question, that I'm the first one who hopes someday we will have a cure for celiac disease, if not for our children's sake, for our grandchildren's sake. But one has to walk before one runs. And today we have nothing other than a gluten-free diet, which everybody understands has inherent limitations. So I think the next 5 years will hopefully be the time when we'll start to see the emergence of one or two medicines that can add something to the armamentarium of doctors beyond a gluten-free diet. And hopefully from that point onward to a point where you could actually see a cure will be the story of this condition over the next 20 years. I think we're at the top of the hour, so I don't know where we go from here. There are a few additional questions. Maybe Nielsen, you could take the one about how long does it take to get TTG levels to normal when you go on a gluten-free diet?
Yes, so TTG levels normalize usually over 6 months to a year. However, it's if the starting level is very high, like I've had patients where the level is close to 1,000, it may take longer than that. And there are people who we're all different and unique. So there are individuals where those levels disappear at a slower rate. So it's important not just to focus on the numbers and more at the big picture. If the patient's getting better and they're doing great and the antibodies are steadily going down, we follow those. And my expectation is that the antibodies will remain positive if I'm not alarmed at all, if the antibodies are still slightly positive within the year starting the gluten-free diet.
Well, thank you all for coming and for participating and for being our source of inspiration.
And I want to give a shout out to all of you out there who contribute to research for celiac disease, because this is a human disease and this is how we're going to move the needle on this. And I think you're all heroes. So thank you.